Hello guys, once again Ijaz Hidayat is with you with new talk. Today we're going to talk about the lung transplant and the role of the perfusionist. So lung transplant should be considered for the patient having the advanced lung disease whose clinical status has progressively declined. Of course, they need a surgical therapy, means they need to transplant the lungs. So we're going to talk about the role of the perfusionist in the lung transplant surgery. Perfusionist is not involved in the patients in a donor lung resections the time they harvest the lungs from the donors. So perfusionists are not directly involved because in this team the nurses and the surgeons, they are the people who are just harvest the donor's lung, and they keep ready the donor's lungs. Transplant team will activate when the donor is available and recipient is ready for the surgery, and it will be take around like 12 hours of the time when we harvest the lungs from the donors. So on-call perfusionist get a call from by our team that the decision made for the lung transplant surgery. So in a lung transplant surgery, we always keep the cell saver in all cases. Cardiopulmonary bypass, there is a 30% chance to use the cardiopulmonary bypass for the lung transplant surgeries, especially the patients who is not able to tolerate the ventilations, or the patients having the difficulty to double lumen endotracheal tubing insertions, so, or even the patient having the severe pulmonary hypertension. So then it depends between the team's decisions by anesthesia, by the surgeon and by the perfusionist, decided either they required to go on a cardiopulmonary bypass or not. So once they decide to go on a cardiopulmonary bypass, so of course we required the cannulations. So in a cannulations we are using normally in our center like a EOPA cannula from the Medtronic. EOPA is the 18, 20 or 22 French. It depends on the patient's height and the weight, and we decide according to that, and we then select the cannula or arterial cannula. For the venous cannula, usually we are using double lumen stage cannula like a 34 into 46, or we are using 36 into 51, or sometimes we are just using only single stage 32 cannula. So to prevent the pulmonary preventing for the pulmonary hypertension, we are using a PA catheter, PA venting, and the size of the PA venting is 13 French. So there is the phases of the cardiopulmonary. The phase 1, we're going to talk about the phase 1. So in a phase 1, we always keep ready our dry heart lung machine and cell saver inside the OR. We kept ready with the venous, arterial and connectors, cannulas and the connectors in standby in the operating room. We keep the ACT machines and blood gas machines available in the operating room prior to start the surgery, and we always keep the assembled ECMO circuit in the OR once we decide the decision make to go on we are planning to do the lung transplant surgery. This is like a phase 1. So in the phase 2, once it was we make a decisions make that the patient will go on a bypass. So as a perfusionist, we prime our circuit as per the hospital protocol. Patient get a fully heparinized and we check and we monitor ACT should be more than 400 seconds prior to cannulation the patients. So no, the routine cannulation of the patients is recipient's cannulation is we cannulate ascending aorta, as I discussed, maybe 18 or 20 or 22 cannula, EOPA cannula, French cannula, and right atrium with the 34 or 36 or 32 French venous cannula 2-stage, and then we cannulate the PA to venting to prevent PA distension or right heart distensions. So once the cannulations performed, the cardiopulmonary bypass established, as I mentioned, with ascending aorta and right atrium cannulations, and we went to the PA catheter with 30 French of the vent, and continue to avoid the distension of the right heart or PA. We always keep the temperature around 34 degrees Celsius throughout the surgery. We keep the heart beating, and during the beating of the heart, the heart is not fully decompressed, so there will be small ejections there. So we always request anesthetist to keep the ventilation from ventilation side. So once we gonna bypass, so as the patients, as you know, the lungs disease patients, their PCO2 is always in the higher side. So the target of the perfusionist is not to decrease the PCO2 suddenly from maybe from 60 or 70 to suddenly to 34. So we titrate the PCO2 with the slow, we reduce the, so we always the keeps around a 2 or 1 in initial stage, and then we slowly come up with the normal range of the PCO2. We check the cerebral saturation throughout the surgery. It should be more than the 50 above. So in case your saturation is decreasing, we always try to keep the full flow support to the patients, and you will get some venous drainage issues during the surgery, but always communicate with the surgeon, and it will going to resolve with the best communication between surgeon and the perfusionist. We advise, and we always using the hemofiltration. So during the procedure, we always using the hemofiltrations, like we use the conventional ultrafiltration if the lungs are wet. We use the zero balance filtration also. So during the bilateral PA clamping, once the bilateral PA clamped, so try to keep heart empty. This is the one of the key point for the perfusionist, the time of they clamp the PA, both PA. So try to avoid distension of the heart. So always the second advice is, once they open the bronchus, so try to turn off all your suckers to get a secretion, to avoid to get a secretion in your circuit. And then we'll come up with the phase 4. So once the procedure completed, rewarm patient with the normal temperatures, and the time of the weaning from the bypass, so come slowly, like stepwise, and always monitoring your PA pressure should be not go higher than such the limitation required by the anesthetist. And once you wean off from the bypass, do the modified ultrafiltration at least for the 10 minutes. So we are doing the modified ultrafiltration to remove the initial cytokinase and excessive fluid which was emitted from the reperfused lung allografts and from the heart. And once your modified ultrafiltration completed, you can come remove your venous and arterial cannulas. So we're going to talk about the muff. So the modified ultrafiltration, we always recommend it to do the modified ultrafiltration after weaning off from the bypass. And the time of your modified ultrafiltration, always having the good communication between the anesthetist and you, so to keep the eye on the pressures. And if the patient is unstable and is not stabilized, so just stop your modified ultrafiltrations. So the time end up of your modified ultrafiltrations, so you have to watch your patient 1 to 2 hours. If the patient is not holding the ventilation and saturations, so the last is your ECMO. So if the patient is not tolerating with the ventilation, then also maintaining the saturations, you can go with the central cannulation, and the same cannula can be used like ascending and venous cannula can be used as an ECMO cannula, and it can be used for 2 to 3 days with the and you can shift your patient to intensive care unit with the support of ECMO, or sometimes you doesn't require the ECMO supports. So hope it is clear to all of you. Enjoy your day. If you have any question, query, please let me know, and just have a nice and good day. Take care. Bye bye.